Hello, my name is Carl Fleischer. I'm the Clinical Research Fellow at ACUM London, and I'm pleased to present to you this rare case of primary dysmenorrhea caused by ACUM or Accessory Cavitated Uterine Malformation. The patient was looked after by the team at ACUM London, led by Mr. Shaheen Khazali. The true prevalence of ACUM is not known, but is certainly a rare abnormality. Asian et al. Described typical diagnostic features for ACUM. These include a solitary lesion located in the lateral myometrium or broad ligament without communication to the uterine cavity or fallopian tube, a cavitated lesion containing functional endometrium surrounded by a myometrial mantle, a cavitated lesion filled with dark brown hemorrhagic content lined with functional endometrium, and a myometrial mantle with concentric organization of smooth muscle. Sethi et al. Described the radiological features of ACUM. Highlighted here are the typical ultrasound features of ACUM. And Neftalen et al. Have described the following diagnostic criteria on ultrasound. And highlighted here are the typical features found on magnetic resonance imaging. We present the case of a 22-year-old with primary dysmenorrhea, mostly affected by premenstrual pain. Her symptoms were refractory to medical management, and she also described heavy menstrual bleeding. Radiological investigations were highly suggestive of ACUM. In this video, we will demonstrate the surgical management of ACUM using robotic-assisted laparoscopy and highlighting a number of techniques to ensure that the endometrial cavity was not breached and that blood loss was minimized. The patient's ultrasound showed a thick-walled structure within the right lateral myometrium, separate from the uterine cavity, with hemorrhagic debris and a fluid level, raising the initial impression of a possible ACUM. MRI, shown here, demonstrated a 3 cm thick-walled structure with low signal enhancement at its periphery and high T1 signal centrally, suggestive of hemorrhagic material, again giving the impression of ACUM, although differentials did include a focal adenomyoma or a degenerating fibroid. Again, you can see here that the ACUM is rising from the lateral component of the myometrium and is completely separate from the endometrial cavity. As demonstrated, the malformation is arising from the anterior right lateral aspect of the myometrium, and the overlying serosa is contiguous with that of the uterine corpus. It is separate from the normal uterine cavity and ipsilateral fallopian tube. The superior pole of the malformation is just inferior to the insertion of the round ligament, which is typically seen with ACUM. We confirmed tubal patency, and this individual happened to have some fairly superficial but widespread endometriosis that we went to excise using the social technique. SOCIA is an acronym denoting a structured framework to aid in minimally invasive gynecology, particularly excision of endometriosis. In this case, both ovaries have been suspended to optimize access. So once this is complete, the origin of the uterine arteries is dissected and displayed here. This is done bilaterally, and this is to then facilitate the placement of temporary vascular clips. And these are placed at the ovarian ligament and the origins of the uterine arteries bilaterally. To further minimize blood loss, diluted vasopressin is then injected overlying the malformation. A total of 10 mL containing 5 units of vasopressin was injected. An incision is made directly overlying the ACUM, and the layers are slowly exposed to show the thick wall of the ACUM capsule. A combination of sharp and blunt dissection is used to expose the capsule. And you can see here that when the cavity is opened, hemorrhagic material is exposed. We're constantly using ICG to ensure that we are not close to or encroaching on the endometrial cavity. Tubal patency is then confirmed and the defect is closed in multiple layers, with the myometrium being opposed using continuous V-lock 2.0 and then the serosal edge being brought together with a PDS 2.0 in an interrupted fashion. Blood loss was minimal, post-op recovery was uneventful, and the patient's symptoms have entirely resolved. Histology showed smooth muscle bundles with a central cavity lined by basal type endometrium consistent with an ACUM, as well as endometriosis from the areas excised within the pelvis. In this case, we've aimed to describe a presentation with typical ACUM features, a safe approach to excision of this malformation that other surgeons can consult when managing patients with ACUM, and aim to add the very limited body of evidence on this rare malformation. Many thanks for your attention.